Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services, on behalf of Jagsonpal Pharmaceuticals Limited, would like to extend warm welcome to this webinar organized by SIG Endoscopy of Indian Fertility Society with academic partner Nayar division of Jagsonpal Pharmaceuticals, makers of Divagest range of natural micronized progesterone, 200 milligrams vaginal soft gel, SRs tablets of 200 milligrams, 300 milligrams, and injection Divagest 100 milligrams. Jagsonpal would like to thank the experts and participants for joining us today. Please note this webinar is streaming live at Facebook and the link has already shared on the chat bot. Please share this with your friends to be part of this webinar. Convener for today's program is Dr. Punita Bhardwaj. Madam is an expert in endoscopy practicing at Unit in Charge Senior Consultant at Sir Gangaram Hospital, New Delhi. The co-convener are Dr. Priya Bhave, Secretary, Indian Fertility Society, MP Chapter, is Consultant Head Reproductive Medicines at Bansal Hospital, Bhopal, and Dr. Mansi Jain, SIG Endoscopy, is Consultant Reproductive Medicine, KJ IVF, New Delhi. Now I request Dr. Punita Bhardwaj, Madam, to kindly initiate this session.
Thank you, Amit. It's a pleasure to be here. We convene this webinar with the idea of initiating the beginners into it. Dr. Deven is going to take a lecture on anatomy. I welcome you all on behalf of SIG Endoscopy, IFS, the Indian Fertility Society, to a talk by Dr. Deven Jogal, who's an eminent endoscopist, and he will guide us as to how we do pelvic surgery with the anatomy in mind. Dr. Deven Jogal, I have seen his growth on a personal level, and he's a fantastic surgeon and a great endoscopist in his field. And he's running his own center and doing a lot of good work. Dr. Deven Jogal. Dr. K.D. Nayar was supposed to be the chief guest. He's on a flight and will not be able to be with us at this point of time. Probably he'll be able to join us at the end of his flight and share some pearls of wisdom with us. Fine then. Dr. Niranjan?
Yes, madam.
Well, another very active and dynamic endoscopist, gynecologist, obstetrician, everything rolled in one. He's a one-man army, and he's a famous doctor in Mumbai, and he's doing some great work, very active academically and clinically. Dr. Niranjan Chavan. Okay, Dr. Sudha Tandon is from Mumbai. She's a joint secretary, IAGE. She's a dynamic gynecologist and obstetrician, and she's faculty at IMAST. I welcome Dr. Sudha and Dr. Niranjan. Please join us and invite Dr. Deven.
He is a member of the IAGE. He has his own center, and I think he works in Gujarat. I have met him many times, and he's going to speak pelvic anatomy from the endoscopy point of view, and then we are going to have a discussion on that, and the forum will be open for any questions. So welcome, Dr. Deven. We are all ready for this weekend.
Yes, sir. Thank you, sir. Thank you very much. And
This is the most important event before AAGL. 1 week
Yes,
before
sir.
AAGL.
Yes, sir. Yes, sir. And I'm very grateful and I'm very thankful to Punita madam for giving me such a nice opportunity. I met her first in Pune, and since then we are, every time we are interacting and all. And she is always supportive and whenever, whatever, like election, IAGE election, whether it was or it was another thing, she is always supportive. She is always with me. So thank you very much, ma'am. Thank you, SIG IFS, for inviting me for such a nice presentation. From endoscopic purpose, from endoscopic view, pelvic anatomy, how it looks like and how it should be, what we should take care of, and how we should go ahead with that. So nowadays we are going more and more complicated surgeries we are going to perform. If we are going to perform more and more complicated surgeries, then it is always necessary to have an idea about the pelvic anatomy. So here we have, this is a little bit idea about the relation of the uterine artery to the other structures, because usually we know that whenever we go into the pelvis, retroperitoneum is the very important point where we need to do dissection. So as we all know that uterine artery is the first branch of the internal iliac artery, and whenever there is a uterine artery, medially we get a ureter. So this is relation of the uterus, bladder, uterine artery, and the ureter. If we go ahead, there is internal iliac artery. We know that uterine artery is the first branch of the internal iliac artery. If this internal iliac artery in continuation becomes the medial umbilical ligament, or it is also known as obliterated umbilical artery. Now, having idea about this, that internal iliac artery, it becomes the obliterated umbilical ligament, first branch, which goes from lateral to medial, is the uterine artery. There are two spaces which are very important in that particular area. The first space is the pararectal space. So as you all can see, that pararectal space, it is space which is lying in between the ureter, internal iliac artery, and superiorly the uterine artery. Second space is the paravesical space. Paravesical space is lying in between the obliterated umbilical ligament and the bladder on the medial side. This is medial paravesical space. There is also something called as lateral paravesical space, which is also known as obturator space, which I am going to show you in my video. So with this anatomical knowledge, I am going to show you one video where all the different spaces, all the nerves, all space like Okabayashi and Yabuki space, and all dissection has been done. So this is video where I'm starting with the creation of the vesicovaginal space. This is the bladder peritoneum, which I am lifting up. And after lifting this, I'm with ultrasonic energy, I'm going to cut only peritoneum on the left side. To cut this peritoneum in this manner, you have to give proper traction and counter traction at this point. You can see here that if you want a proper dissection, then you need to give a proper traction at this point. This is the bladder pillar, which I'm cutting right now. After cutting it, I'll make a more space inside. This dissection can be done by blunt and sharp dissection. So whenever it requires, you can do blunt dissection, or you can go for sharp dissection as well. This is a rectovaginal space. Usually this space is necessary when rectum is adherent, and usually this space we are going to open in cases of endometriosis where rectal involvement is there. There you'll be able to see two leaves, two different area, two different area of denon-villus fascia. One is going towards the vagina, one going towards the rectum. So here you can see, this is, now we are coming to the retroperitoneum. So in retroperitoneum, if you want to go, this is the triangle which you need to remember. The triangle made of, this is the round ligament, this is the IP ligament, and this is the impression of external iliac artery or the psoas muscle. So with keeping this picture in mind, we will go ahead. What we'll do is we will cut open the peritoneum, which is lying on the round ligament. that is also known as the lateral technique or oncological approach. We'll cut open round ligament. After cutting round ligament, all the peritoneum lying on that, I'm going to merge it with my bladder dissection. This is the peritoneum lying on the retroperitoneum. I'm going to cut. Only peritoneum should be cut, and I have to remain superficially. Right now, I'm remaining lateral and parallel to the IP ligament. If I give traction to the IP ligament, it becomes easy for me to cut and to enter into this peritoneum or in this space. You can see here that after doing this, what you can see is this is the psoas muscle, which you can see right now. This is genitofemoral now, which is seen here. If you come more medially, this is external iliac artery. And if you come more medially, this is the ureter. If we go for further more dissection, if I remain in between the external iliac and the ureter, the external iliac vein you can see, which is being protected. This is a common iliac bifurcation. So you can see from here that common iliac is bifurcating into the external iliac and the internal iliac artery. And just medial to the external iliac artery, the bluish structure is the external iliac vein, which you should be very careful of. So further, if we go for this dissection, and if I remain on the internal iliac artery, the first branch which is going from lateral to medial is the uterine artery. Always, always, always remember that uterine artery, though it is artery, it is never pink in color. It is always bluish in color. So that is the very typical point about the uterine artery. Right now, I'm remaining in between the ureter and internal iliac artery, and superiorly the uterine artery. The space which is in between the ureter and internal iliac artery and the uterine artery is the let's go space. Now we are going to the lateral paravesical space, which is lying lateral to the obliterated umbilical ligament. We have to go up till the levator ani muscle. This is also known as obturator space. So this till the levator ani muscle we are going. If we come to the medial side of that and remaining above the uterine artery and go up till the levator ani muscle, the space which we are going to open is the medial paravesical space, which you can see here. So all this dissection should be done remaining above the uterine artery. So right now you can see a medial paravesical space here, and uterine artery and internal iliac artery and ureter. So this is the area of ureter. This is ureter, you can see here. This is internal iliac artery, you can see here. This is external iliac artery. The space between ureter and internal iliac artery and uterine artery superiorly, this is the pararectal space, which is also known as let's go space. The space which is lying above the uterine artery and bladder medially and laterally the obliterated umbilical ligament is the paravesical space, which is also known as medial paravesical space. If you go just lateral to that, lateral to the obturator, lateral to the obliterated umbilical ligament, that is the lateral paravesical space, or also known as obturator space. Fine. So this was dissection on the right side. Right now, because this was a case where lymphadenectomy I had to perform, so I went on, and this dissection we are going remaining on the internal iliac vein. So you can see here that how much care you should be taking off in this area. Now, this is, we are going towards the inferior hypogastric nerve. You can see here with Babcock, inferior hypogastric nerve is being held. And if we remain in this area, the medial pararectal space, which we are going to open, it is also known as Okabayashi space. You can see here inferior hypogastric nerve. that nerve has to be preserved, and knowledge of doing dissection of this nerve is very important for nerve sparing surgeries like nerve sparing radical hysterectomy or nerve sparing endometriosis surgery. Now, this is uterine artery from its origin we are taking with the help of ultrasonic energy. And right now, what we are doing is we are remaining just at the level of tunnel of Bhardwaj. This is a ureteric tunnel. And here, with utmost care, we are doing ureteric tunnel dissection, because if your energy, with your energy source, there are high chances of having a ureteric injury. The space which we are making here is known as Yabuki space. And all the vascularity at this area should be taken care of. Here you can apply clip as well to block or to decrease bleeding. Now, this is almost area from where ureter is inserting into the bladder. And this is almost end of our dissection, because more than that dissection is not required. So you can see here that movements at this particular point is very gentle, and it has to be very gentle. Ureter lateralization is very important thing. From all these sides, whatever tissues we want to take, we are taking this out, and this is the starting point of the pelvic lymphadenectomy. So we are remaining just lateral to the external iliac artery. All the fibrofatty tissues we are going to remove from this area. Right now we are working just lateral to the external iliac. We need to save genitofemoral nerve, and all the lymph nodes or tissues lying or covering external iliac vessels, we need to take it off. So there is combination of blunt and sharp dissection. This area is very important because you go just little bit inside and there is external iliac vein. The problem with vein is once you put any pressure on vein, you feel like it is white, and you start your dissection. Once you start your dissection, you realize that vein injury is there because any pressure on the vein and color starts getting white. So this is external iliac vein. We are remaining lateral to the external iliac vein right now. Now this area is very important because if injury to this area, any vascular injury into the area of obturator, it becomes a little bit difficult to control it. Gently, you have to strip off all the fibrofatty tissues. Only care should be taken that unnecessary pressure should not be given. I am stripping off all the fibrofatty tissues lying on the external iliac artery. And here this is very important because there is a connection between external iliac and the obturator, which is also known as corona mortis. This. So corona mortis is known as corona mortis because if it starts bleeding, it is very difficult to control that bleeding, as bleeding is from obturator vein as well as from the external iliac vein. Now this is en bloc lymph node dissection, and this is a roadmap of doing such kind of surgeries. This was a radical hysterectomy. So you can see here both the external iliac arteries. You can see here psoas muscle, then femoral nerve, obturator nerve from both the sides, internal iliac artery, inferior hypogastric plexus and inferior hypogastric artery. There is a ureter, and this is the end of our dissection. So this is the pelvic anatomy, which can be seen on laparoscopy view or endoscopy view, you can say. So this was the end picture. And in just a minute. So, and thank you. With this, I'm here to answer any questions. If you we are doing, this is my Facebook and YouTube channel where we do almost every day, or whenever we get good cases, we do live surgeries, voiceover. So if anyone is interested, you can just scan this code and you can join us. So with this, I'm ready to answer any questions. If there are any questions, I'll be happy to answer it.
Dr. Deven,
Yes.
am I audible?
Yes, ma'am. How are you, ma'am?
Good, good. How are you doing? We just saw today your Facebook live hysterectomy of a 30 weeks uterus.
Yes.
Yeah. So he has a wonderful setup, though it's in Kutch, but you know, a small place, but his setup is really wonderful. He has all the equipment and he has trained his staff. You know, the three OT assistants of them, I think they are so very well trained. They can really help anyone to get out to operate. So I think you're doing marvelous job, Dr. Deven. And today's talk is also wonderful. So, you know, today we are meeting so that Dr. Punita said we have to discuss a lot, you know, and I think from the time that we were doing simple surgeries for hysterectomy, where we were not opening the retroperitoneum, the time has changed, where we have to quite often know about the anatomy, right? So, you know, to open the retroperitoneum, there are two ways, the anterior and the posterior approach. So can you just elaborate on that? And then depending on the time, we can discuss each disease as to what we need to understand and what we need to, you know, look into, and what we need to really follow the steps. So which are these two approaches and how are they different and where are they useful?
Right. So should I stop sharing?
Sorry?
Yeah. Okay.
Yeah.
So there are, I wanted to stop screen sharing. So now it is done. So what actually madam is saying is there are a few different approaches of doing retroperitoneal dissection. So one approach is a lateral approach, one approach is the medial approach, and one approach is the anterior approach. So there are total 3 approaches. In lateral approach, whatever you saw just now in my video, that is a lateral approach. It is also known as oncological approach. So in which what we do is, this is a round ligament. This is if we are talking about right side. So if this is round ligament, this is IP, and this is impression of external iliac. We remain in this triangle, triangle, and what we do is we stretch round ligament, cut open round ligament, and we go inside. So that is known as oncological approach, because in oncology or in hysterectomy for CA, where we need to remove pelvic lymph nodes, we need to go as lateral as possible, and we go inside. There is one more approach which is also known as
how many sorry to interrupt, because I thought Dr. Punita, please tell me if I need to be, you know, asking such a way, because I thought that is what is relevant.
No. You just go ahead.
Yes.
Feel free.
Yeah. So in the lateral approach, how much lateral you are to the IP ligament? You know, if you're very close, then you will not get into the, because you see, as a beginner or as a person, we need to know as to how much lateral we need to go.
Yes, yes.
Is there any rule lateral to the IP ligament? So, you know, can you just have some sort of a roadmap or some guidance?
Yes. So laterally, if you want to take out pelvic lymph nodes, then you have to go at the insertion of round ligament and cut it from there.
Okay.
Okay. If you are doing it for benign surgeries, you should not be going that much lateral. So what you can do is, this is, let's say, IP ligament. So what you can do is, this is IP and this is round ligament. You just take up peritoneum remaining 1.5 centimeter away from the IP ligament. Give stretch to the IP ligament medially, and ask your assistant to hold peritoneum 1.5 centimeter away from the IP ligament and lift it up.
Right.
After lifting it up, you only put one nick or only give one nick, with whether with monopolar or with dissector or with harmonic, and immediately you will get space, because immediately gas will go inside.
Right.
Then what you have to follow is, you have to keep on giving traction to the IP ligament to the medial side, and you have to keep following that same line up till the from where the IP ligament starts. If you are not comfortable with this much, and if your assistant is not trained enough, then what you can do is, you can hold peritoneum lying on the IP ligament, and you yourself take it on the upper side, and then you cut. But it is better and safer way is to give medial traction to the IP ligament and ask your assistant to lift that peritoneum, which is approximately 1.5 centimeter lateral to the IP ligament.
All right. So this is the lateral approach.
This is lateral approach, yes.
Then you said there's medial approach and a posterior.
Yes. So then there is medial approach, which is also known as endometriotic approach. So in endometriosis, usually we use a medial approach where we need to do ureterolysis. Usually endometriosis, where rectal involvement is there, what we do is, after restoring a routine anatomy, what we do is, we start with the ureterolysis. We go up till the tunnel of Bhardwaj by doing ureterolysis.
Where does this start from?
We start ureterolysis. Usually we start at the level of pelvic brim.
Okay. So at the SI joint or the sacral promontory at the SI joint?
Sacral promontory, where sacral promontory is, at the level of sacral promontory, just lateral to there where ureter is starting. From there we start doing ureterolysis. And the ureterolysis will continue up till the tunnel of Bhardwaj, because if ureteric involvement at that area or puckering at area of parametrium is there or not, we have to see. So we will continue till there.
Here you remain medial to the ureter, am I right? Here you remain medial to the ureter?
Here usually what we do is, I personally...
You're on the ureter.
Yes. I personally what do is, I remain above the ureter.
Above the ureter.
On the top of the
on the top of the ureter. Yes.
And on the remaining, now little bit about ureterolysis, if we are talking about, I remain on the top of the ureter, and let's say that if this is the ureter, okay. So what I do is, I do my dissection on the top of the area, and whenever I'm doing dissection, for the dissection point of view, my energy source will not be on the vertical line. It will be on the transverse line. So I'll be taking up peritoneum, I'll be going in, and I'll be separating like this. Then I'll cut this way, again I'll go in and I'll separate on the spread apart movement will be there, and I'll be separating on the lateral side, I'll be cutting from the upper side. So that gives me bloodless dissection usually.
Yeah. Okay, thank you. And what is the posterior approach?
So in posterior approach, what we do is, we take IP ligament, we make IP ligament little bit lateral. So now after making IP ligament little bit lateral, the anatomy becomes little bit clear. You can see ureter, you can see iliac vessels which are going. So after lifting IP ligament on the lateral side, if you see space in between the ureter and the iliac vessel, you just lift that peritoneum up, give one nick, and you remain in between the ureter and external iliac vessel. So if you remain in between, same space you will get, which you get remaining on the lateral approach in between the ureter and interiliac artery, same space you will get from the medial side. So then what all you have to do is you have to keep on doing this dissection remaining near to the interiliac artery, so that whenever uterine artery separates from the interiliac and it is going to the medial side, you will be able to recognize it.
All right. So, so to sum it up, the lateral approach is the oncology approach. Am I
Yes.
right? Or if you want to do the uterine at source,
Yes,
or a myomectomy or a hysterectomy,
yes, yes.
right? And the medial approach is for the endometriosis.
Meteoritic approach usually we say, but if you are not comfortable with lateral approach, you can go with medial approach as well to do uterine artery ligation from its
Right.
origin.
Right. Okay. And posterior approach is for?
So lateral and posterior.
Yeah.
So medial or posterior, you can say these both approaches are same.
Same. Yes.
So then remaining approach is anterior approach.
Right.
So in anterior approach, what we do is we trace the obliterated umbilical ligament, which is going up, and you hold obliterated umbilical ligament, which is on the anterior abdominal wall from there, and you trace that ligament and come down in the retroperitoneal space.
Right.
The problem is every approach like lateral or medial approach, what we do is from internal iliac, we go inside, and the first branch of internal iliac, which is going from lateral to medial, is uterine. But it is exactly opposite in anterior approach, because in anterior approach, when you come from above downward, the first artery which you get will be the superior vesical artery or maybe the middle rectal artery, and
Right.
then second and third artery will be the uterine artery.
Right. Right.
That's important to understand.
Yeah.
That
Yeah.
every approach has a different organ system involved, in the sense whether you are going from top downwards or lateral to medial or medial to lateral. The
Right.
idea is to remain safe, I think, primarily.
Yeah.
Yes, and in retroperitoneum, I think everything is important in
Yes.
Your voice is breaking.
retroperitoneum, but in retroperitoneum, I think ureter is. Am I audible now?
Yeah.
Yeah.
Better.
So I think retroperitoneum, ureter is more important. Though everything is important, but most important, I think, is ureter. Because
Yeah, that,
at a time you will not realize that you have injured it, and by the time you realize it is little bit late. So when if let's say if I have injured uterine, we did uterine just maybe yesterday. I was showing to my fellow uterine artery ligation from its origin. I did it and it started bleeding. So fine. What I did was I came little bit on the upper side, internal iliac artery I took, and I started coagulating it, and it is fine. So if uterine artery is gone, not an issue, because वो दिखता है, वो पता चलता है कि वो bleed कर रहा है, उसको at a time solve करना है. Problem with ureter. If you injure ureter and you don't know you have injured it, so by the time you realize it after 10 to 15 days, it becomes late.
Right. And what is the basic difference on the right side and the left side?
I think little bit, that is my personal opinion. Again, I cannot say that 100% it is like this, but I'm using a middle port.
Yes.
So I'm using suprapubic port. So for me, going to the right side or going to the left side becomes equally effective and equally good. So because same distance is there. So people, those who are using an ipsilateral port, so they are putting their two ports on the left side.
Right.
They are doing dissection from the left side. So doing dissection from both the port on the left side becomes little bit difficult when you operate on the same side.
Right.
Going opposite side is easy because you are going to the right side, but it becomes little bit difficult. This is my personal opinion. Doing dissection on the left side, going into the retroperitoneum.
Yes. I think everybody is different. Some use the suprapubic port and some are ipsilateral surgeons. So I think
right. I am an ipsilateral person, and
Yes.
I just adjust my hand movements accordingly.
yes.
The end result should be the same. What you
Yes.
do on the left side and the right side, and gradually you get used to your approach. You
Yes.
become comfortable using both your hands and being safe with that.
Yes.
Dr. Niranjan, I see, is very quiet. Where is he?
Yes, Dr. Niranjan, now on stage is yours.
I'm really very happy to see the interaction which is going on, and so I was just listening. Sometimes you have to be listener.
No, sir, you
No,
can't
no.
be the listener. You have to actively give your inputs.
Okay, no, I agree. Dr. Deven has directly actually entered into the pelvis, and he has shown us very nicely the anatomy of the lower pelvis. It's very important that when you start as a beginner, or even as much as you are doing an advanced surgery, we have to understand that the anatomy may be same in a diagram, but when it comes to an individual patient, it varies with the size of the uterus, it varies with the size of adhesions, it varies with the pathology which you are encountering. The placement of the organ, say a ureter or the uterine artery, is going to be somewhat deviated if it is a broad ligament fibroid. Obviously, if it is a subserous fibroid, it is going to obstruct your positioning of the ports also will change depending upon the size of the uterus. Most conventionally, most of us now, irrespective of the size, we go ahead with the supra-umbilical port, because that gives you much better maneuverability and a good panoramic vision. And injuries can do occur anytime, but the most important thing is that you should be able to identify first the injury, whether it is a vessel, whether it is ureter, whether it is a bladder or the bowel. But unfortunately, sometime it's like driving a car. You have both the sides, side mirrors. You have a rear mirror, and you have to see the front windscreen. So you have to have your vision at 4 places. It's not only just at a particular speed of doing the surgery, but your vision has to be everywhere, which will see not only your positioning of the instrument which you are holding, but including that of an assistant. Because a certain cautery burn on a bowel or an injury by a grasper can create a catastrophe, and the magnification of these, the present lenses is so good that it is 10x. Like even if a small bleeder is there, it is going to be magnified. So there's nothing to be panicky about. But most importantly, as you enter either from the second port or the third port, you need to avoid the inferior epigastric artery. It is a basic common fundamental you should understand. And I have seen multiple injuries which have been referred to our Sion hospital. I come from a tertiary center. Of course, we have got much more of an obstetric case referrals. Dr. Sudha Tandon was also once upon a time, many decades back, a part of the faculty, and well, she has totally now gone into IVF and endoscopy. We are very happy about it. But what is important that at the end of the day, you can damage anything. It's very important to know the anatomy. Dr. Deven, you have shown very nicely how the internal iliac further goes into the obliterated umbilical artery, how you have to know the identification, especially of the retroperitoneal dissection, the pararectal space, the urinary bladder space, the Lasgo space. It's very important. And the ligation of the uterine, it's very important. Okay. I still remember Dr. Shailesh Puntambekar when he does radical surgeries. You have to push the fat. You have to be away from the any organ, but push. And I still remember when you were showing those videos, I was recollecting him, how he talks about especially when he is at the pararectal, rectovaginal space, when you're trying to push and try to get the uterosacrals in the radical hysterectomy, or when you're trying to go more laterally for the parametrium so that the ureter is dissected away. So it's very important that all these steps are to be understood. And injuries can occur, but we need to understand the port placement, a skillful surgery with proper assistant. You should have your assistant commonly being the same team. Otherwise, then again you go back to the square one. Of course, I'm in a teaching institute, so I need to change the assistants more often so that each and every one comes in a rotation. We do not operate like 4 to 5 cases or 8 cases a day for endoscopy. We operate once a week. Our OT gets once a week, but once a week is a dedicated OT where we at least operate 3-4 cases. And there you have to understand the smaller nuisance. And really, Deven, you have done a wonderful job. I'm sorry, Sudha, I was not a part of the initial discussion which you were asking, but I was at the later half. Regarding the position of the surgeon, I think most of us are comfortable with the ipsilateral port placements, and operation is much better, so that there is a good mechanical advantage. Especially initially we used to do, I think 70% of endoscopic surgeons have back issues by now when they reach 50s and 60s. And really you need to do more of yoga, and you need
I
to.
beg to differ. I've been into it for a long, long time.
Yes.
And if you are ergonomically smart,
Yes.
then I don't think you need to have back issues. Yes, yoga is good for everyone, any which ways. Why only the endoscopist? And obviously, should also be yoga.
No,
Uh,
no, because I have gone through the process of the whole spinal issues when I was very young. Now also you have that issues. Even the best of endoscopists, how many best you are, it still hurts. Of course, the process of aging is going to take over the toll of, because what you are doing is 6 hours, 8 hours, constantly a surgery, which is an occupational hazard. You have to understand, nobody's
It's
got
only in
you.
the beginning, Dr. Niranjan, it's only in the beginning. It's later on you become quicker at it. And in
Yes,
the beginning, you are much younger and you focus on the thing, and you're beyond your learning curve. You can, what say Dr. Deven?
madam, let me complete. I never interrupted anyone.
Sorry.
So what is important, that what I do, you need to have your back lying. Let us come to the basics of an endoscopist also. You're doing a surgery from say 8 o'clock till 5 o'clock. At what cost? It's very important. But you need to also, there is some soul in your body and it needs some time to heal. Regenerative procedures are always there. So even if you are young, I see so many on social media, young of, I'm not so old also. Sudha will also agree with my statement. But there are so many of the cases which are been done, ureter, laparoscopic, cysto-ureteroscopy, and so many things are happening. It's totally, I saw that day some 30 kg myoma dangling from the top here, and all these things. Okay, fine. But don't give a wrong message. It's very important that you do a precise surgery to a point where the safety of the patient is very important. And for that, anatomy of the pelvis is very important. You need to also understand that you have to give time to your healing process also. Please take care of your back, because I can tell you so many names which are very highly reputed endoscopists who are having issues. So you need to go slow. You need to have a proper, as Dr. Punita has said, you need to have a proper ergonomically balanced way of operating. You need to transfer your weight on one leg at a time and then transfer your weight on the other leg. You cannot just put the total weight of your body on one side and be, in this position. So please understand the things. And of course, all are going to be a very good endoscopist. Yes, Sudha, I can see your hand. And I think that's what I would like to tell about this lecture. Thank you.
Yeah, Dr. Niranjan, I think you have raised very important points, and probably Dr. Punita can take it up in another webinar. So I think let's, and one important thing other than the back is your upper, upper arm.
Development of shoulders.
Develop it, and you, especially women, have to work for their upper body. It's just one sentence. Going back to the pelvic anatomy, Dr. Deven, now you, I think you have beautifully explained. And I think the basis of how to do it is really very well. We have given enough time for it. Now coming to and Dr. Niranjan talked of fibroid, especially a lateral wall fibroid. So I would like to know what different, like for a lateral wall fibroid, how different is the uterine artery and what you need to know in these cases. And whether, second is whether, and we can be quick about it, because there are lots of things which I feel one should understand when we are talking of pelvic anatomy, in myomectomy, in hysterectomy, in endometriosis, especially, I think there's so much that we can do in endometriosis. So let's first talk of, a lateral wall fibroid, whether you're doing myomectomy or hysterectomy. Some quick tips about how to tackle the uterines. Anatomically point of view.
Yes,
Yeah.
yes. So lateral wall fibroid, the other things remain same. So what you do is you go to the lateral to the IP ligament, you cut open the peritoneum. That remains same in each and every case, because that is the gateway from where you have to enter into the
Yes.
retroperitoneum. After going in, second problem is you will not get that much good space, which I have shown. In my video, what you saw was there was no fibroid. So it was smooth like cakewalk, like I'm going inside and I'm dissecting and retroperitoneum and all.
So the vaginal manipulation, or you want to have the myoma spiral, to have a good space? What is your choice?
General manipulation in cases of lateral fibroid may not work very well. Though I am using vaginal manipulator, and my one assistant is all the time on the vaginal end manipulating, but it may not help. So for going into the retroperitoneum with lateral wall fibroid, so you can use a instrument with which you can hold or give traction to that fibroid. That is a better option, and you will not get that much space. So what you have to do is constantly you will have to ask your assistant to change their position, because you will be working in a narrow space. So it is not a good space, which you saw in my video. So that will be narrow space. So constantly you will have to ask your assistant to change yeah. So you will ask them to change their instrument. Second thing, you always give to your assistant, always Babcock should be given. None other than Babcock. No sharp instrument, no other instrument.
Very good point.
Yes. Third thing is, what you do is not only closed Babcock. You train them and you tell them to assist with open Babcock. So whenever you get a narrow space, you are working there, you need more space. You ask them to open their instrument so that two jaw of the Babcock, he or she will open, then you will get a more space inside. So that is some tips working in a narrow space. And you can also work with the two jaw of your instrument, rather than only keeping closed instrument there. You can open that instrument and you will get more space from the medial side. I'm talking about right side if you are working, and your assistant will give traction with that two jaw on the lateral side, so you will get more space to do. Third thing is, whenever there is lateral fibroid and very less space, you may not get a good space for suturing. So as we all know that there is suturing, there is a bipolar, there is a dissector, there is ultrasonic, with every things clip with which you can go ahead. So in narrow space, clip is always better. In narrow space, whenever you are working, to ligate or to uterine artery from its origin, clip is always better option, because you go in, apply clip, come out. That is done. And in suturing, we all know we require two different this needle holder. It goes inside and you do all this maneuver. It is not possible there. And with ultrasonic or with energy source, if it starts bleeding, it becomes difficult to control because the space is very narrow. So then suction karna, and then mop karna, then kisi ko bolna, then again pakadna, it becomes a little bit difficult.
Yeah. So probably either a clip or bipolar.
Yes, bipolar is another option, but bipolar, if space is very narrow, then
of course you take care of your ureter, and be really close to the internal ilex and the space which you have, whatever space that best you can have. So if the bipolar would be more reliable, or a clip would be more reliable than doing with the harmonic, is what I understand. Yeah. And do you need to take the uterine at its source for every case of hysterectomy?
No, ma'am. It is a wrong message. Usually people say they take it wrongly. Uterine artery from its origin, it is not required in every case. There are specific cases where you require it, like multiple fibroids, and so there are specific indication for doing uterine artery from its origin, not in each and every case. That is one. Second thing, why we are doing it in routine or normal cases, because we all understand that for practice, if you go and you do uterine artery ligation only in cases where it requires, which is once in a while, maybe if you are doing less number of surgeries, or then it is not possible to do at that time. I will not name it, but she is a very renowned person in South India. She was with me for advanced training. She went back and she is like, we are working in a very big hospital, so we cannot do uterine artery in normal patients. So it has been like 6 months or 2-3 months or 5 months, I don't remember. But now she's like, now I'm comfortable because I'm doing it in each and every case. So it is not indicated in each and every case, but for practice, you have to do it in simple cases. You understand anatomy in simple cases, then you go and start doing it in different cases.
Yeah, I think this is a very relevant point, because all of a sudden in a difficult case, you cannot do it unless you have good practice. So you have to start with simpler cases and knowing it, learning it, and then practicing it. You may take half an hour once first, and then it slowly comes down to 5 minutes or a few minutes. So I think that point is which I think is very, very, very relevant. There is one question in the chat box. Which book from Dr. Deepa Kapoor? She wants to know which books to follow to understand and read more.
I think for retroperitoneal dissection and altogether for endoscopy, I personally think book is not a good option. For reading, there are so many books available. There is retroperitoneal anatomy book from Dr. Shailesh Purtambekar sir. I remember when I was there with Dr. Punita madam, we were there to Shailesh sir to learn my onco training or retroperitoneal training. He has published so many books. But I personally think for retroperitoneal dissection or for advanced surgeries, book is not an option.
Yeah, because you may read and you may remember at that time.
Nothing like the real thing.
Yeah, nothing like learning it with your own hands.
Yeah.
You just
You know your anatomy, but nothing like the real thing.
Yes. So
that's an interesting discussion. Thank you so much, Dr.
So you
Sudha.
tell me when I have to stop, Dr. Punita.
Yeah, I think we are done. Dr. Kuldeep is waiting for the next conversation.
Okay. Thank you very much, Dr. Deven. I wanted to ask about prolapse surgery. Maybe some other time Dr. Punita can.
Yeah, we will catch him again.
Endometriosis also. I think we have, peritonectomy, what to do and all. I think there are a lot
of this thing. I started with the anatomy because, it's important for people to understand that anatomy is so important.
More on the anatomy today.
Yes.
Yeah.
We have discussed more of advanced endoscopy. But
from basic to advanced, little bit, So unless you know the basic, you can't go to advanced.
So I feel there are many, probably the viewers will increase over a period of time, and when they go back and see, they are going to be happy to know about advanced. But basic is also very important, because I think all are out of, say, 100% of endoscopies, 80% are not doing advanced endoscopy. You have to understand. There are only...
Dr. Niranjan, the time has come that you do not know which case you would want to do it. So somewhere you have to learn it.
So basically, out of 100 endoscopists, there might be only 15 to 20 or 30 people who are doing very advanced endoscopy. Like, I'm not talking about myomectomy or ovarian cystectomy, or I'm not talking about, surgeries like like TLH. Okay. Those are done now routinely by even my SRs.
Yes.
Even my SR also is doing TLH, ovarian myomectomy, ovarian cystectomy, etc. But when we are talking about further than that, you need to understand that, it should not happen that if there is a complication and you have to open the patient, you don't know anatomy.
Yes.
It's very important. Today,
yes.
Know your open surgery first before you get on.
Yes, I'm not saying that you start with vaginal hysterectomy, I mean P repair, then A repair, then vaginal, then abdominal surgery, and then you finish after training. Okay. But there are many residents which come to me as a medical college, I'm talking, because whatever you might be, a consultant in a private hospital or a very super human being as an endoscopist. But you did your MD or MS in a medical college, no? You did not do in your consulting room. You did that on patients which were either a deemed university or a medical college which catered to poor patients. So how many of them actually underwent endoscopy training? If you see the medical college infrastructure in any part of India, they are hardly having endoscopic setup also for that matter. So we need to have that mindset also to, as a HOD or as a professor, to see that you are abreast with the total newer technology, newer equipments. And if you don't know that, please go and learn.
Yes.
Yeah, I think that's a very good
That's
point.
right, Dr. Niranjan.
Yes.
I think
I just have to make one comment before it just take a minute of mine. You see, somebody asked about the books. I think constantly viewing these unedited videos on Facebook and YouTube, unedited, goes a long way in teaching. You know, so whenever you have time, Facebook and YouTube videos are always there. So,
Yes.
you know, unedited videos, you please see whenever you have time. And it's not that one can't find time. I think one must realize. So
Has
just
to be done with voice, with
yes,
explanation.
with voice, unedited with voice. Yes, I totally.
that's
Yes.
right.
Very
Thank
true.
you very much, Dr. Niranjan, Dr. Sudha, for your
Yes,
input
madam.
and participation. I'm grateful to you. And thank you, Dr. Deven, for an exciting and thought-provoking presentation, as always. Thank you very much. We will now go on to the next
Madam.
session. Thank you. Dr. Kuldeep. He's our mentor, SIG Endoscopy. Dr. Kuldeep, I would first want you to say a few words about how you thought about SIG Endoscopy, and then we'll start our conversation. Dr.
Thank
Kuldeep.
you. Thank you, Dr. Punita. It is really great to join today for this conversation. I was just listening previous discussion. It was very interesting. And let me congratulate you on organizing this talk show. It was really a good idea. Instead of going through only lecture, if we can have more discussion of such sort, I think that
so much of experience.
Yes,
People are so experienced, and nobody understands the depth more than the experienced person.
yeah. So thank you for that. As far as the endoscopy is concerned, I think the story goes long back when I was a student, when I was doing my MD. Since then, there were two things in my mind. One was, of course, infertility. That time it was not that great advances. And second thing was endoscopy, which apart from routine training, that was always in my mind that yes, endoscopy is one area which is going to replace a lot of things in our practice. So that is how it always was in my mind. And whenever you get opportunity to do things, you tend to introduce it in your practice and in your teaching and other things. So that is how endoscopy has been my working practice since long.
Right. No, but that's very far off. It's very, very inspiring, your journey in the field of both infertility and endoscopy, because I think you were in a government job, if I'm not wrong, and then you left all that and all the security of a government, all the perks that the government job holds, that you jumped wholeheartedly into private practice. And that was quite a risk and a challenging situation. To be able to envision that, okay, this is the path that you need to take and this is where the field is going to go, is very exciting. And I would like to know more about your thought process at that time. you thought that the government setup is not letting you do what you wish to do, or you thought, no, the direction that I want to take, the focus that I want to shift is towards endoscopy and infertility? What made you think that this is the road you want to travel?
See, Dr. Punita, problem is in the last discussion also that Niranjan was saying something regarding the medical colleges. I worked in the medical college for 14 years.
Wow.
Started my senior residency, then I was a lecturer there, then became reader. As far as the infrastructure is concerned, I was fortunate enough to be working in a hospital which was attached to University College, Delhi University, and working in a capital hospital. But there are not many medical colleges still after so many years in country who are really working towards the endoscopy surgery or infertility for that matter.
Right.
Infrastructure not available. The willpower is not there. In government medical colleges, that is still lacking.
Right.
Means there for 14 years, I tried. I was only person. We were having leisure that time in our department.
Right.
4 years, it was just packed there. It was not used. When I joined, I opened a box. After 4 years, the warranty was gone. It was functioning.
Okay.
So see, we were having a very nice operating microscope. So funding, as far as was concerned in our hospital, funding was not issue. It was just the direction which was required at that time, and it is the same situation at present in most of the medical colleges.
Nothing much has changed.
Yes, direction is not there. People who can take decisions, they are not taking decisions. They are not introducing. They are not introducing the technique to their junior colleagues. That is that problem there means it may be little harsh to say that this is the situation at present.
So
And
you
that
think
will not change
only the inertia? It is only the inertia of the decision makers, or do you think there's something more to it?
See,
No, inertia
Madam,
is one important part of the whole situation. Then many of the places there is the direction is going towards some other thing. Like it is always said that there is a lot of pressure, obstetric pressure on the residents and other things.
Right.
See, but they are open surgeries are being done, and they are exposed to open surgery. But when it comes to the advances over the period, they are not being introduced into the department functioning. Then how the people are going to learn?
So
if I may answer your question, if I may answer, I absolutely agree with Dr. Kuldeep. It is not about inertia. It is regarding personal skill development also by an individual faculty. I had no money when I had to go abroad to learn things. You should have that passion to go and learn.
Dr. Niranjan, if may I interrupt? That's my next question coming up.
No, but let me answer. I am
Ji.
not finished, madam. So it is number one, you should have that passion of doing something out of the box or trying to get, you are so young, 26, 28-year-old. You have seen 3-4 years of residency and you have been trained with open surgeries. As Dr. Kuldeep said, so many obstetric cases you have tackled. Now you need to have, to see the other aspects of obstetric and gynecology. So people are going outside and taking fellowship, or they are trying to go, paying lakhs of rupees to get that 6 months, 1 month, 15 days training. And they are our own, the faculty are also our renowned people. I mean, it is not going for today. It has been going for ages and ages, that people are going, say in Kerala, people are going to Delhi, people are going to Mumbai. I get so many phone calls. Kuldeep might be getting, Sudha Tandon might be getting, you are getting, madam, where to go, what to do. See, that passion is there, that urge is there, but there is no guidance. Or if they have guidance, they are confused. Or if they are confused, they have guidance, they don't have money to pay that lakhs of rupees to get. Or if you want to go abroad, I did not have money, but still I went abroad. My father took loan. I took loan from my in-laws. So it's a challenge which everyone goes through it. But at the end of the day, you need to have that passion. And then there is something like politics which goes also in the department, or for that matter, anywhere in a medical college. I don't want to dwell on that issue.
I think so. Yeah. Let's
Yes.
keep up.
Yes, let us not go through it. So we need to
Nir-
change our mindset. Why people then have to leave medical colleges and join private hospitals? Why? Secondly, the instruments break, madam. They are not, like they are used again and again. Then you need instrument. You will see our private practitioner colleagues in all IAGE conferences or any other, they will go and buy new. They will buy some 18,000 instruments, some 20,000 hand instrument, some Caesar which has come, that has come. That inertia is there in government medical colleges, because then again you have to fill that justification form, then tender, and then L1 and L2, etc. So
But-
it is a process which goes on. We need to change a lot of things, madam.
Yes. Thank you so much, Dr. Niranjan, for your input. Coming back to Dr. Kuldeep, sir, what do you think is the difference in approach to learning of beginners of today and your days? Do you think there is a difference in approach, or do you think you require the same passion? The means are there. Now that the lot of things are happening in the endoscopy and infertility field, even in India, so they don't really need to go abroad for their basic training. So is there a difference in approach that you feel, or do you think your days and these days it's the same?
No, there is a lot of change. In our time, we were not having means, as well as the way guidance was not there. Now, over the period, a lot of things have changed, and of course, the passion is one thing which you cannot just infuse. It has to come from within. Okay.
Exactly.
But if you are having the right direction from the department where you are working, you need not to go anywhere. That is what. So that is not changing over the period. Still, people are, as far as the endoscopy is concerned, we have changed the scenario in infertility quite a lot. Now we are having structured programs available in the private setup as well as in the government setup. Not everywhere, but yes, they are available. You need not to go. Like in my time, I was when I went for my training in infertility, there was not much choice.
Yeah.
I had to arrange, like Niranjan was saying, you had to arrange money and all that. Now that thing has reduced
Considerably. Yes.
over
Because a
the
lot of
period.
things are happening in
So
India.
you can yourself. Yes, but
Generation is the lucky
endoscopy,
generation. Our
the-
parents had to buy everything. And then we were in such a situation, and our children, or the, the present generation, has got everything on the platter. They are a lucky people.
Yeah, they are lucky people, but only thing what I want to say, as far as the endoscopy is concerned, endoscopy should be considered as a basic curriculum.
Absolutely. Absolutely.
Starting from 50 days, and they should be exposed. But why it is not happening? Again, apathy towards the branch. People don't want to go for learning themselves because they are too old. and they are decision maker. They will not allow the junior faculty to go. So there's a lot of politics happening at that level, and that's why the scenario has not changed. Means I was working there in the hospital. The same scenario is continuing for 20 more years.
Right. True.
How things would have changed by now, but it has not changed. So there are problems at all levels.
True.
Passion is there. People are going here and there. But why? If you are working in a medical college, by 3 years you should be learning at least basic. You can always adapt. You can always adapt to the advanced techniques.
Liking.
Even basic is they are not exposed. They are just exposed to open surgeries and obstetrics.
Right.
So endoscopy, actually, it has to come into curriculum. It was in the curriculum, but still it is not available to the even at SR level.
Yes. No, it's not there at any level. So if it is not there as a PG level, the SR level is not there.
Can I just add few points, Dr. Punita?
Yes, sure.
Yeah. So I think Dr. Kuldeep has raised a lot of points, and he's been very upfront and very open and very frank about it. I think that's I really appreciate it. And the difference that has happened is, you were talking of differences. The equipment, the camera system, what it used to be when we started with the single chip camera, now it has gone to HD or even a 3D system or a 4K system.
4K.
So that is something.
Dr. Sudha, when I started endoscopy 35 plus years back, when I was a student, there was no camera with me.
So that's what I'm telling. Simple thing is camera system has improved. Secondly, in most of the centers, they are exposed to advanced like retroperitoneal dissection right in the beginning. So my take is that
there is a gap
in a medical college. There is, I do not know. It just a thing which is crossing my head is: are there still DNCs being done? Why aren't they all converted to hysteroscopies? Are all ectopics operated laparoscopically? Are all ovarian cysts operated laparoscopically? These are simple cases. So I really do not know. I wish that no DNC, no gynec DNCs are done, because hysteroscopy is what everybody has to learn, and there are so many cases of endometrial polyps, fibroids, and septum, which you cannot treat with a DNC.
Yes, exactly.
So these are very simple cases, so I do not know whether the residents are exposed, whether the seniors want to do it, they don't want to do it. I think each unit is different.
So each unit, yes.
Yeah, probably they have to be a lot of, they have to think within.
Introspection.
Introspection is what everybody should be doing. And
Madam, they are members of MRCOG. They are member of Royal College of Obstetric Gynec. But they do not know endoscopy.
That is what is introspection. As to
what is the point if you do not know? You are unit head. You are an associate professor in a medical college.
That's exactly.
You are not a member of the local society.
No,
but you are a member of Royal College of Obstetric and Gynecology.
Whatever maybe the situation is, introspection is what one needs to do, and find ways of how you can do it. I wouldn't know. Maybe have 2 hours or 1 hour every OT, do one case.
Yes.
That's what we did. We also had obstetrics. I used to start at 6 o'clock.
Dr. Sudha, I don't think we wish to get into the debate of medical colleges versus the private sector. The next question, Dr. Kuldeep. Point well, though. What are the advantages? Dr. Kuldeep, are you there with us?
Yeah.
What are the advantages of the structured training format of today? The private sector is taking up the cudgels and trying to get into training people. Do you think there are advantages? Do you think people can just leave their work and come? Or do you think the right time is when you finish your residency, when you know a bit of your open and things, and then get into practice of learning laparoscopy? When do you think is the right time? And the advantages of structured training?
See, ideally, the training should start from the PG days, then moving on to the senior residency, and then it has to be in as a consultant or practice. So that is the ideal situation, but that is not happening. So that's why structured training, even after doing your MD or senior residency, if you are having a structured training for at least 1 year, see, we are having a lot of short training programs
Yeah.
are
Not
going. Yeah. So I don't think that is the right way. Of course, whatever is available, people are going and learning. But if we have to really improve the situation on the ground, then there is a drastic need of having a structured program at least for 1 year, at least
right.
for one, whatever
True.
level.
Because a lot of people are dissatisfied with fellowships that are going around. They say 2 days, 3 days, you don't
Yes,
gain, you just get a certificate, but there's nothing much you learn.
I don't think. And as you grow older, you will not have time to go for 6 months or 1 year. So that's why people are looking for shortcuts. Okay.
Right.
So ideal time for training is as early as possible in, so you can give more time to that particular branch, whether it is endoscopic surgery or for that matter ART or any other fetal medicine. But you have to start early and you have to plan early. In some of the places it is available to the people.
Right.
Most of the places it is not available, and that is the problem. And that's why I think the mindset at higher level should change. This is high time. And we see now the situation as far as the endoscopic surgery is concerned in India, we are having lot of trainers. I
True.
think there should be some mechanism to bring them together. I know the people have tried, but again, when you are thinking big, you have to shed off lot of things which come in the way, and that doesn't happen. That's why a good structured program, we are still looking for that. At least for 1 year there should be some program which can be of our junior colleagues who are just trying to get into the field of endoscopy.
Right. So the crux of acquiring skills in endoscopy is passion and focus and starting early.
Yes, you have to start early. Otherwise, what will happen? You will be going for you may not acquire whatever is required. Okay, and then you come back, you don't have patients, too many patients of that sort, and again you will lose interest. So
Right.
until unless you are starting early and you are training yourself in a structured way, in a format, you will be able to do better. That is what I feel. And these type of programs should be made available somehow. I don't know. We are working. I have been working for quite long. I know few people who have been working, but it is not coming up. We are not able to put things together. And probably in there will be a program which will be offered at early stage after the post graduation or after senior residency, and people can come and join for 1 year or 2 year, whatever is possible, and they get a better trained outcome.
Right. Yeah, that's nice. But what advice would you extend to the beginners of today by the time your structured format comes into play and in fruition? What advice would you tell the youngsters that how to go about it? Lose hope, get into these fellowship 2 days, 3 days program, or, because once you don't know the specialty, you can't begin on your own, especially at such a young age. You might not have the patience, you might not have the experience, you might not have the necessary equipment and know-how. So how do you think a person should start from the beginning?
See, if you are fortunate enough working in a place where you are exposed to routine endoscopic surgery, always you have to look for opportunities.
True.
Opportunity will not come to you. You have to look for opportunity.
Exactly.
Passion always there. Means if you have decided that you have to go for endoscopic training, you will find the way out. Try to get most of the opportunity now. Opportunity is coming. At present, the scenario is, I'll just describe the scenario in India at present for learning.
Gee.
You are having conferences, workshops. They are plenty. And many times you are getting very nice exposure through these conferences.
True.
Through these workshops. So try to get exposed to all workshops, whatever opportunity comes into way. That is one way of learning, introducing yourself to the field and getting the motivation. Okay. Second thing is, now the social media is available. Lot of things are available on the net. Lot of there was something like unedited video. That is the problem. Many times you don't have many unedited video on the net. Most of the time they are edited video. So try to get unedited video if you can get. Even edited video, you will learn lot of techniques from them, and then try to get into a program. Few programs are available in India at present. I think Maharashtra is having one year diploma in endoscopy. In South India, there is availability of 1 year diploma. Unfortunately, in North India, there is no program available.
I wonder.
So so these are the ways you can introduce yourself into the field of endoscopy at present.
So that was lovely talking to you, Dr. Kuldeep, and I appreciate that you are on a holiday and you still dividing time with us. Extremely grateful for that. And your pearls of wisdom to the youngsters will take them a long way. I thank you from the bottom of my heart for being there for all of us. Thank you very much for your time and for your advices. Enjoy your holiday.
I think we need, I will like to sum up today's conversation by saying one thing, that there is a need for a structured program in India who can train the youngsters for a longer period. There is no shortcut. I don't believe in 2 days training or 5 days training. So they are being offered at a huge price. Huge price, because there is a demand. So I think this time the leaders in endoscopy, they should come together. At least if 4 people come together, we can start a very good structured program for youngsters for a long training schedule we can provide, and that will really change the scenario.
I hope so, and amen to that. It's a tall order, but yes, there has to be a beginning.
Yeah.
Thank you so much.
Thank you so much.
Thank you, Dr. Niranjan, Dr. Sudha, Dr. Deven. It was a pleasure hosting all of you, and I hope you enjoyed the webinar as much as we did putting it together. Thanks a lot.
Thank you.
Thank you, Dr. Punita, for inviting us. A lot of thought-provoking thoughts, and from Dr. Deven we learned a lot. and of course from Dr. Niranjan also, and from you, your interaction with Dr. Kuldeep. I think it was really fantastic. We really learned a lot.
Thank you,
Thank
madam.
Thank you very much.
Today it was something different and not, of course, we had a scientific content, but the discussion was also very practical, and I think it has touched the heart of many consultants who are there, and also the postgraduates. And
I think it's the need of the hour. I mean, we need to really think about it and start implementing it. Don't you think so?
yes,
Ji.
Yes, it is the right time. I must say it is the right time. Only the opportunity we need to grab. We need to have like-minded people on the board, and then it can be started. Anyone can start. Means what I am saying is it is the open philosophy. Anyone can take it.
Yes.
So yeah.
search your mentor, what passion you want, endoscopy, infertility, search that mentor, be with him for not few months, but few years.
Exactly. So I think the present generation is also in a hurry.
Yeah.
They don't want to go through a learning curve, which is so
Learning curve.
required.
Go through the
Yeah.
rigorous training of a mentor, and really it will make a lot of difference to you.
Exactly.
And, just by fly by night, or just like a honeybee, or on butterfly, will not take you anywhere.
Right.
Yes.
True.
Agreed.
True.
That is there.
So
Deepika.
I'd like to thank everybody, all the experts present here and all the participants for this webinar. So now here I take an opportunity to present before you our natural micronized progesterone brand Divagest. We have Divagest 200 mg soft gelatin capsules and also 100 mg injections of Divagest. We also have sustained release tablets 200 and 300, Divagest SR 200, SR 300. We have Verena nano silver vaginal gel for especially after episiotomies and the surgeries that you would want to apply for a pro-healing effect. It comes with an applicator for internal application as well as external. And Digest EndoReg. So we look forward to your support to all our products. Also, thank you all very much. And next, we hope to see you. This is another program that we'll be having on happy, healthy pregnancy, which is being organized by the UP chapter of ISOPAP, West UP chapter, and it is on 9th of June. So the webinar ID is mentioned if anybody wants to register. So this is all, and your permission, ma'am, do we
Yeah,
end?
most definitely. Thank you so much, Deepika. Thanks a lot.
you.
Thank you so
Bye-bye.
much.